whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and chief medical officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. All right, so today we're talking to Dr. Raymond Rupert, primary care physician with more than 40 years experience in practice. He's now a serial entrepreneur and founder of RCM Health Consulting, and now the CEO of Healtheon, working to advance primary care through technology and innovation. Today we're talking about the economics of primary care. Dr. Rupert, thanks for joining us.
Hey, Jordan. Fun to be here.
As always. So to kick it off with an interesting anecdote on the topic of finances. Like last week, there was a doctor's conversation going on Facebook, and somebody was asking about how much should they be paying to buy into a clinical practice. And then there was about 20 responses with people telling them, don't do it, $0. It's a scam. Like, it's just a liability at this point. Like, any clinic asking you to pay to join and be the owner is trying to take advantage of you. And then there was one voice that chimed in with, believe it or not, there are actually profitable clinics out there, and you should be paying, your proportion of 3 to 5x on the EBITDA of the clinic every year. Yeah. Why is this, profitable clinics seem to be the minority of the ones out there?
Yeah, that's a really good question. So a doc spends 40 years, helping thousands of patients. He's got 3,500 files, some active, maybe 2,000 are active. And he wants to retire. So he puts it up for sale. And what does he or she get? The big fat $0. Okay, because
the goose egg.
Well, he gets the goose egg because all the earning power is on the guy or gal that wants to retire. So the question is, how do you create annual recurring revenue is the sweet spot. Like, ask anybody who's, finance aware or savvy, and you mention the magic word, annual recurring revenue. Annual recurring.
That's the secret.
That's the secret. That's the secret sauce. So how do you get her going? Well,
it's very labor dependent, right? How does the doctor uncouple themselves from being the source of revenue just based on their man hours and input time?
Yeah, great question. So we started a company called Healtheon to do exactly that. So how does Healtheon do that? Well,
how do they do that?
Yeah, Healtheon sells monthly plans, just like an insurance plan. In fact, some of the plans include insurance and other benefits. So a plan could be $20, $30, $40, depends on what's folded in. And that becomes the annual recurring revenue.
And so this is the sale to the patients from the clinic, and then that's representing that recurring revenue that exists in perpetuity, other than just patient care minutes.
Yeah, this is a very disruptive idea that patients would actually contribute for things that do not have a provincial fee code. Like, they're not paying for you to do their appendectomy. They're paying for tech, they're paying for the nurse practitioner, they're paying for sort of access to critical illness insurance. They've got a bolted-in relationship with virtual pharmacy. There's all kinds of secure messaging. Like, there's an entire platform that essentially perfects primary care. And then the secret sauce is, like, where does it come from? Does Justin write the check? No. The patients, if they agree, if they want, can opt to buy a monthly plan. They don't have to. And the benefit of some people buying a monthly plan is that everyone gets enhanced service, better service, more attention, better messaging.
And so what does that cover you then? That's like your sick notes, your uninsured services, your, what forms being filled in be inside that? Like, what all would you wrap in that bundle?
So that's the historic bundle. Block fee, okay?
Yeah.
Well, This is 2024, soon to be 2025. So in 2025, what's in the bundle, in the plan, is an AI-enhanced text stack. So instead of calling the doctor's office 12 times, in which the voicemail is full and there's no email, we provide secure two-way messaging. Okay? And so you can say, and you can book your own appointments through the text stack. And then you can type in the chat bot, or now you can talk to the voice bot, Kaya. And Kaya's been trained on all the things that the practice does. And Kaya can send a message for people that are blind or senior citizens that don't like typing. They talk to Kaya. That's a conversational AI bot. They book the appointment, get the messaging, get their chest x-ray done, they get their repeat prescriptions. So the customer experience is what? Enhanced?
Probably a lot better. Well, then where does this fall on the, I guess, the public versus private debate, or like that two-tier system? Like, is this part of
we're
the clinic?
Jordan, you've got a bifid mind. No, we've got a public system, and what Healtheon is doing is enhancing the public system. Okay?
And so what is the charge for then? Like when the government is looking at the clinic?
We haven't yet concluded what's in a plan. So now say the doctor hires a nurse and a physician assistant. And does the Ministry of Health of that province pay for their salaries? The answer is no, Jordan.
In a roundabout way, kind of?
No.
They'll fund the doctor, funds the clinic, funds the nurse?
That isn't how it works. Primary care docs cannot afford a team. Okay? So you can charge for a nurse's hours or time or physician assistant or whatever. Okay? Let's throw that in there. That's called team-based care.
Okay.
And now, when you got a team, the nurse spends 20 minutes with grandmother, and the doctor spends 5 minutes with grandmother. So what happens to the roster on that practice? The roster size.
Oh, they can handle more patient load at that point. They've got more team members.
A factor of what? 2.
Double? Yeah.
Double. All right. And that helps the 6 million people that are out in the cold, that are unattached.
Yeah, no doubt.
Yeah. Okay, well, let's keep going. So now we add critical illness insurance. $20,000. Have a heart attack, stroke, cancer, something. The insurance company, big insurance company, gives you a check for $20,000. Does that help you if you're off work with pneumonia or something?
Definitely, of course.
Oh, okay. And now you want enhanced service with your pharmacy. So Healtheon has a direct link with virtual pharmacy. So we can deliver the amoxicillin up in Moosonee or anywhere. Okay, so the customer experience is what? Enhanced. We're building on and perfecting the public system by investing in the private overlay on the public system.
This podcast was brought to you by Cherry Health, the healthcare jobs network with over 35,000 jobs across Canada and the US. Physicians, nurses, pharmacists, and all other healthcare professionals can sign up for free. Start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across North America. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with thousands of new jobs posted every week. www.cherry.health to get connected today. Well, it's interesting because this is the problem with the team-based care model that's so often talked about right now, is that the funding and the fee codes and things just have not been set up in advance to actually facilitate that. And this sounds like a way to get there.
Yeah, so if you've got a doc who's, working from 7:30 in the morning to 7:30 at night, they burn out. So then you end up with no doc. On the other hand, if you put a nurse in there, you put a PA, physician assistant, or an IMG as clinical assistant, all of a sudden, the doc can go golfing on Wednesday afternoon. They don't burn out.
That's the dream.
The 2 hours of unpaid admin work that they're doing every day, hello, goodbye. It goes over there to the team. So the secret sauce is team-based care, okay? And the ministry doesn't fund it, except in family health teams. And even some family health teams, because of the escalation or increase in costs, are underwater. Okay, so I had a group of NP-led clinic with about 5 NPs.
Yep.
They were underwater, so each of them was slicing off some of their salary to fund the rest of the clinic. Not good.
Not great for retention.
You got it. Okay, so we talked about that, and now the question is, if the doctor is charging $30 a month and signs up 500 patients after year 2, what's the math? So let me do the math. 500 times 30 times 12 equals $180,000. So all those
That'll get you a lot of team-based care.
You gotcha. Okay. All of this is Healtheon's value prop to perfect primary care. Improve the public system.
Gotcha. Okay. That's starting to make more sense. Because, yeah, but making the revenue and the bottom line pan out, like, it's just very tough right now for clinics, and having any kind of advantage to actually make ends meet clinically in these small businesses, I think probably goes a long way.
You got it. So that only took 2 years to cook up. And I used to, as a doctor, I got a MBA from Rotman. I worked in investment banking. I edited 2 books on corporate finance. So I got a little bit of, a couple neurons that know what finance is. And we got it all cooking at Healtheon.
Right on. And how's the launch been?
Great. Yeah, we're just rolling. You got about 30 docs and about 200,000 patients in there.
Oh, nice. Wow. Okay. So we're off to the races.
Some of the clinics are walk-in, so they have many more patients. And so, life's good. Yeah, we just want to help a lot of patients.
It's interesting that the private sector has had to innovate its own solution to the funding to the team-based care model, because again, it just it's been so slow to come from the top down. Like here in Alberta, there just isn't even fee codes to support this yet. I think there's a few pilot clinics that have gotten this going, but it's just not accessible to most.
I think that when you look at a health system, and whether a health system can be only funded by the public sector.
Yep.
There are 3 economies that only have public sector. Okay. Do you know what they are?
No, what is that? Health and what?
No. If you
Education?
look at health systems, there are 3 countries in the world that only have public funding. Okay? Here they are. Number 1, North Korea. Number 2, Cuba. And number 3 is Canada. So we're in a
top 3
friggin' bizarre club here, okay? It's a little bizarre. Anyways, let me tell you about what my friends in Australia do. Okay? You been to Australia yet?
Not yet. It's on
They're
the bucket
lovely.
list.
They talk like us. Like they're nice people. The minute you land in Australia, you feel at home. Okay, except when the kangaroos hop by. So what happened in Australia about 40 years ago is they had universal health care, just like Canada. But someone very clever in their economics department decided that you'll have to excuse the puppy here. They really needed private capital. So the government formed their own insurance company owned by the people, like a not-for-profit, called Medibank. And then everybody has public, and some people could buy a policy with Medibank, owned by the people, not-for-profit.
Okay, and that's comparable price-wise to other privately offered health insurances or from other countries?
Cheaper, because it's a not-for-profit.
Okay, even cheaper.
Yeah, cheaper. Cheapy. Yeah, okay. So what happens? 30% of the population, even though they all have universal, buys Medibank. Now the dollars start coming in, and what do they invest in? Infrastructure. So now we've got a stack of public infrastructure, where the walls are falling down and the paint is peeling. And then we've got new infrastructure, which is called the private infrastructure funded by the insurance company. Okay, so somebody comes in and they need a special procedure that's only in the private area. So what happens?
Got to go private.
Well, no, they move them over to private and they do it without cost because the infrastructure is already there. Okay, so you got a public system with an overlay of private, not-for-profit health insurance. 40 years, go to Australia, and you need your appendix out. It's a piece of cake, okay? Because they got beautiful infrastructure, great service, great place to be.
That's an interesting way to handle it. I was talking to a doctor from Australia recently, and she echoed that sentiment. She said it seemed to get better down there after they went to the 2-tier system.
I wouldn't call it 2-tier. They allow private
What would
health.
you?
It's an option.
Okay.
2-tier is a bad word because it excludes people. This is inclusive. Everybody.
What's the difference, I guess?
Well,
in practice,
when you have a public system that's improved by the private sector, you're enhancing the service for everybody. So you can't use.
Okay, gotcha.
You can't get that private public dichotomy in play because that's not what we're talking about.
And so the private side being owned and not for profit by the government then kind of dances that line between the two.
Yeah, it's a not-for-profit. Okay, so here's the weird thing in Canada. Because there's no private health insurance in Canada. Okay, but there is. Okay, so I'm going to let you in on a little secret. Just don't tell anyone.
My lips are sealed.
There are a number of people, sort of more sophisticated people, who understand the issue of waiting lists. And they're not used to queuing up because they're just a bit fancier than your average dude. So they're buying private health insurance from the U.S., so they live in Canada. And so if they then get sick, they just call up the insurance company and they send them to Baltimore or Boston or somewhere fancy. And they're covered. The cost of that, $3,000 per person per year.
Interesting. Okay. So medical tourism winds up bridging some of those gaps at the same time.
But you can't use it in Canada. You got to go to any other country, and there you can use it. So what happens?
Well, we're seeing that more and more anyways. People go to another province to get their hip replaced. They'll go to Turkey for their hair, Mexico for their stomach stapling. It's already just happening more and more.
Yeah, probably $1 billion a year of medical tourism. People going, we just had a kid in Guyana with transposition of the great vessels. My company, RCM Health, deals with complexity. So this little 8-month-old is very complex. And the parents looked around and said India, and he went to India. The pediatric cardiac surgeon that did the case had done 12,000 cases. So transposition of the great vessels was, check that box. And little Cronby or whatever his name is pinked up. Used to be blue, now he's pink because the parents had an option. Yeah, they rejected him at sick kids.
It's wild that people are now preemptively getting health insurance in other countries, just anticipating friction with our system here. I've never heard that before, but that makes so much sense.
Breaking news for Jordan, absolutely. Every day it's happening.
I guess you don't even have to live on like a bordering city. You can just, at some point, it's going to make more sense to just fly down there.
Yeah, like if you're in Winnipeg, you just say, "Oh, I've got private health insurance," and just on a plane to Rochester, Minnesota. Like, just off you go.
Interesting. Very interesting.
Anyways, so we're hoping that at some stage that private health insurance will be part of Canada so we can build private infrastructure and some of the hospitals that are kind of tired can get renewed. Yeah.
When do you think the change is going to start happening? Will it start happening? Does it seem inevitable in your perspective?
Well, the only thing we can do at Healtheon is try our best to improve primary care, and the rest of the system will, hopefully there'll be some leadership and it'll improve over time.
So at the end of the day, hopefully the team-based care model coupled with just influx of likely private funding start actually improving that access to care for everybody.
Absolutely. So, it's really, really essential because the tragedy is that RCM Health, we're seeing 30-somethings with advanced stage 4 cancers because they never got a chance to go to their GP. So is that a tragedy?
Absolutely.
Yeah, well, that's happening. Nobody's talking about it, but we're seeing it. So if we can fix that so that the 32-year-old has got access to a GP, can catch the colon cancer early, get it resected, and live the rest of their life without a problem, instead of having her come into the office stage 4 with mets to liver and lung because she couldn't reach her GP. Like, excuse me, I'm getting emotional now. Like, this is a very emotional factor. So, anyways, we're hoping and praying that Healtheon is recognized as a valid change strategy for primary care, and we can help people. We really like helping patients.
Well, it makes a lot of sense. I mean, again, going back to the revenue problem with clinics, and then this offers a nice down the middle solution to actually keep the doors open, provide more patient care, get more people through the door.
Yep. And the other thing is, like, there's this thing in the paper today about how docs in Ontario can join HOOP, the pension fund. Did you see that at all?
What's HOOP?
Oh, it's the hospital pension fund. So all the workers at the hospitals are part of HOOP. It's a very large pension fund.
Okay.
So they're letting the doctors join HOOP, which is incredible. Now that is profound for younger doctors. Okay, because they can start investing in HOOP, and someday they'll retire and they can go fishing or whatever they want to do. Now, what happens with Healtheon is if the younger doctor brings Healtheon in, they've got money that can be contributed to HOOP. And it'll be properly invested, and so they'll have a comfortable, safe retirement.
And sorry, what's the connection between the Healtheon side and the HOOP fund?
Okay, so a doctor brings in Healtheon.
Yep.
They double their capacity for patients, so their gross monthly billings doubles.
Gotcha. Okay.
They've got new revenue from Healtheon, the plans that are sold. Now there's extra surplus cash, which can now be invested with HOOP, the pension fund for doctors. So that was a wonderful, wonderful announcement by HOOP.
Bringing up the bottom line. That's interesting because I don't know. I've heard a lot about the some of the independent physicians pension funds and things like that, and then MD Financial has theirs too.
Yeah, well,
and so now you can just tag on with it.
But HOOP is like a $40 billion fund. Like you got great company when you're in HOOP. They have extremely astute, smart financial managers, and they're protecting your assets. Your livelihood and then retirement, having a pension is like phenomenal for docs because otherwise, remember, they're selling their practice for $0 and they're moving to a smaller house as they retire.
Yeah, the nest egg isn't very voluptuous at that point. You kind of have to have it sorted out on the other end.
So now, newer, doctors coming in, they have the ability to contribute to a pension fund like HOOP. They've got excess capital, surplus capital that can be invested through either the increase in gross provincial sales or Healtheon. So, it's all sort of coming together.
I love that there's now options for this because, yeah, before it was like, how do you increase the bottom line? You're capped on your revenue. You really can't like make more per hour because the fee codes are set at whatever they're set at. You can only work so many extra hours until you're just burnt out and ready to give up. And then at that point, it's either do you pivot into offering uninsured services or, kind of just shifting gears altogether in terms of what you offer.
We've already cooked the solution up here. All they have to do is call healtheon.ca. Just go to this.
Okay, let's get them in there.
Just get them in there. We got it all cooked up. Okay, so now there's another problem.
What's the other problem then?
Okay, so the CBC article points out that they surveyed Ontario doctors and 2,300 GPs are going to retire within 5 years.
Okay, doesn't sound good.
Well, it produces 3 million unattached patients.
And then the influx of doctors, of course, not even close to keeping up with demand.
No, you just create a catastrophic public health crisis here. Anyways, so we've looked at ways of putting in plans so that there's continuity of care for the practices. The doctors don't have to retire. They just have to go down from 60 or 70 hours a week down to 20. So we're using IMGs. What's an IMG?
How does that play the role here then? The international medical grad. How does that fit into the picture?
Okay, so we actually, there's 12,000 IMGs in Canada flipping burgers. So many of them will be trained in the management of a practice. So we actually set up a course, or we are in the process of setting up a management training course at it used to be called Ryerson University. It's the Toronto Metropolitan University. A 3-month management program for IMGs. So then the IMG comes into the practice as the operator of the practice. In some cases, they invest money in the practice. And you put the team in place. And then you introduce Healtheon. So the doc can now, an IMG can take your blood pressure. They can't write the script. They can't do the rec or whatever. But, after practicing primary care and wherever, you can take somebody's blood pressure, which is, I'm not sure that's a controlled act.
No, I don't think so. The MOA can do it. The nurse can do it. The IMG can do it. The machine in the pharmacy can do it.
Yeah, the guy the garbage man down the street here can take your blood pressure. Anyway, so the IMG comes in as essentially a manager of the clinic because we're training them.
Yeah.
They invest some bucks. The doc goes from 60 hours a week to 20. They're there as the prescribing doc, et cetera, et cetera. They have to be present. But life gets better. So
does the clinic have to source their own IMGs then, or is this part of the Healtheon system?
Call Healtheon. You got
Interesting.
It.
Okay.
Oh, little bit of a enhanced work life for family docs that want to retire someday. And then we build in continuity so the 3,000 or 4,000 patients don't get dumped. So, anyways, so hopefully.
And then is this available how far across the country right now then? Ontario only, or is Healtheon actually beyond it?
Yeah, we're all across the country in our little startup. Yeah.
Okay, very cool.
And our solution is totally scalable, and we keep enhancing it, and we're having fun.
Okay, right on. The team-based care model coming sooner than we think, I guess.
No, it's all out there. So all they have to do is go to healtheon.ca, just click on the link, and we'll have some of our staff jump to it.
How difficult is it to actually get set up, onboarded, integrated into your operations?
Yeah, so about 2 weeks. We do 95% of the work. We customize the setup for the clinic. We train the staff. So, very easy. It's all there.
Very cool. Right on.
So I hope I've contributed to the general knowledge of mankind here. And
Absolutely.
people have
How to get more bucks into clinics. I mean, this is just like probably public enemy number one right now.
yeah. Well, people can go to Healtheon in about a week, and a voice bot will be there called Halo and answer any question. So,
Clinical questions too. Can I go ask it about
we don't diagnose autoimmune encephalopathy. No. We talk about the clinic and what it does and how you make an appointment and all that stuff.
Right on. All right.
We're not-
Okay, cool.
we're
I
not
hope to see more of this.
We're not getting the AI voice bot to prescribe or anything. Like, that's not happening. So thank you for mentioning.
Right on. Well, Dr. Rupert, I don't know. Anything else for the afternoon today? Anything else you want to cover before we sign her off?
No, I really enjoy my relationship with Cherry Health. I think you guys are doing a great job out there informing the primary care docs and the public, hopefully. And,
Well, thank you. We're doing our best every day.
Good. Hopefully, we're going to contribute to improving the public sector. Okay.
Here we go. All right. Well, Dr. Raymond Rupert, thank you so much for joining us today. Really appreciate the insights and how to up that bottom line. Thank you for joining us this week on Leaders in Healthcare. If you enjoyed this episode, please like, subscribe, or leave a comment. And if you found this episode helpful, don't forget to share it with your network.